gluteal region, and these are providing sensations to the skin of the gluteal region. Here's a plastinated specimen where they kept them intact. So here's a superior cranial nerve, and here's posterior femoral cutaneous that might have on one cadaver. See how it's parallel in the sciatic nerve? Or we might, I don't know, that cadaver might have been returned to Davis, I'm not sure. And inferior cluneal nerve. Sometimes you'll see like little remnants of the inferior cluneal nerve on our cadavers. But anyways, just sensations of the gluteal region. You're not going to see them on the cadaver. So moving on. We'll start kind of putting together in our minds a picture of where these cutaneous nerves are going. And we'll end up, hopefully, by the time we get to the foot, with a map like this in our brains of the major sensory nerves to the skin of the lower limb. We talked about lateral femoral cutaneous nerve half hour ago. I talked about how femoral nerve actually gives off anterior cutaneous branches. You can see that in orange. The obturator nerve, right, which is going to the medial compartment of the thigh, actually provides some sensation to the medial thigh. And now you can see down here the longest branch of the femoral nerve, saphenous, of the medial aspect of lower limb. That's the guy traveling with a great saphenous vein. Anyways, we'll start adding to this picture as we go along. Back of the thigh, posterior femoral cutaneous nerve that we talked about last week. So those are the ones we need to know now. Then obviously back of the gluteal region, cluneal nerves. But eventually, this whole picture will kind of coalesce in our consciousness. So, let's now shift back to thinking about the sacral plexus. Last week we talked a lot about sacral plexus because this is the stuff we saw in the gluteal region. And this week we're going to think a little bit more about lumbar plexus because that's a lot of what's innervating the thigh, not completely. But for example, obturator nerve, L2 to L4, femoral nerve, L2 to L4, lateral femoral cutaneous nerve, you get the idea. So let's think a little bit about lumbar plexus. The best place actually to see lumbar plexus is inside the cadaver when the GI tract's been removed, so like in here, and we have some examples of that. It's harder to see, especially the cutaneous branches of lumbar plexus after they've exited and headed down the thigh, and the reason is when you remove the skin of the thigh, oftentimes those nerves are damaged. It's really hard to keep lateral femoral cutaneous nerve. Here you can see it coursing over iliacus, but we have it on one cadaver. Okay, it's hard to see branches of genital femoral nerve. It's easy to see genital femoral nerve in the pelvis. So, like what I usually say is, best place to see a lot of lumbar plexus again is in posterior abdominal wall. All right, ilioinguinal nerve and iliohypogastric nerve, tough to see out here, easy to see up here. These guys are providing sensation. So the way I think about it is H is before I in the alphabet. So kind of like the skin just below your belly button, that's iliohypogastric. And then heading down to the scrotum in males and labia majora in females is ilioinguinal nerve. So these first two lumbar plexus nerves are sensory mostly, heading here. Let's look at them individually. So ilioinguinal and iliohypogastric. These are, technically speaking, motor and sensory, although primarily sensory. if you think about their course, right? So again, right, this is where it's easiest to see them. Lumbar plexus inside posterior abdominal wall. We remove the GI tract. Ilioinguinal, as you can see, to exit, it actually has to pierce your lateral abdominal wall muscles. So as it does that, it actually innervates them. Okay, and then it becomes purely sensory, and it heads down to the scrotum in males, maybe the majority of females. Sensation. We can see that in the cadaver, posterior abdominal wall. Out here, difficult to see. Its brother or sister, iliohypogastric, really similar course, okay? A little bit higher up in posterior abdominal wall area, but it's also piercing lateral abdominal wall muscles, also therefore partly motor. And then it's heading really similar location to ilioinguinal, but a little bit higher up, so that's why I say kind of like below the belly button. Iliohypogastric cutaneous innervation. Okay. Genitofemoral. The place you're going to see this is again posterior abdominal wall. The way you look for it is you look for psoas, which is really easy to find, and this nerve pierces psoas. And on a few cadavers, you can actually see it then divided into its two branches. If you're wondering what its two branches are doing, the genital branch, more probably pronounced in males and females, is going to the cremasteric muscle and the scrotum, which elevates the testicles of the male. And the femoral branch is actually going under the inguinal ligament, just doing a little sensation in the thigh. Okay. Genitofemoral. So we're going to see it piercing psoas. You're going to see iliohypogastric and ilioinguinal in the posterior abdominal wall. You're not going to see them when they're becoming sensory. Lateral femoral cutaneous, if you want to see this, and differentiate it from iliohypogastric and ilioinguinal, this is going right over iliacus. Iliohypogastric and ilioinguinal are higher up. They're above the iliac crest. Does that make sense? Okay. So lateral femoral cutaneous is below the iliac crest, traveling over iliacus, under the inguinal ligament, sensory, lateral aspect of the thigh. We have it on one cadaver. You can see it on this plastinated specimen going over sartorius. Okay, knee. Any questions about that? Is that okay? Okay. I would like the thigh people who are presenting to show us these in the posterior abdominal wall. And so I can help you do that. Just to remind you, what I'm envisioning is the thigh presenters Friday, you do a big day, and what I really want you to do, if you don't do it Wednesday, maybe you want to relax Wednesday night, then Thursday, you read my PowerPoint inside and out, and you look at some glue link for the thigh, and then Friday, you show up having already seen cadaveric photos, and you do most of your time Friday. I'll help you out. And then next Monday, right after lecture, you can go in a second time, okay? And just kind of end up feeling more comfortable, but that'll be enough time. But I would like you to find a cadaver where you can see these things on the posterior abdominal wall. And there is one cadaver in particular that's really good, and it's on that list. I forget which one it is. It might be number 5. I don't remember. Okay. Okay, let's talk. Question? Okay, let's talk about the knee. A lot of important osteology here. A lot of important connective tissue structure here, and yeah. So for example, here's that adductor tubercle for one part of adductor magnus. Adductor part, there's a little hiatus like that. Oh, they're not showing Gertie's tubercle on here, but maybe it's up here, Gertie's tubercle. The tuberosity is where the patellar ligament is going to attach. I'd say, you know, if you're presenting, you really wanna map it out. You wanna find, we have multiple cadavers, including the new cadaver, where, you know, you can bend the knee, flex the leg at the knee, flip up the patella, and only then you're gonna be able to see the anterior cruciate ligament, etc. So you wanna do that. But you wanna find a cadaver where all the overlying posterior structures have been removed. See the back, there's a couple of cadavers where you can do that too. So you have to map it out. You might be using 5 cadavers for your presentation, okay? Because you need some head up, you need some head down, you know, whatever. So the knee really is multiple articulations that we have to think about. There's actually a technical femoral patellar articulation, and then there's an articulation on the lateral and medial aspect of the femur and tibia. So if you think about these femoral condyles, each of them is forming an articulation site. Why are they colored blue? To indicate the hyaline cartilage that covers the ends of long bones typically, right? And that's cartilage that often wears out as we age, causes bone against bone friction, pain, etc. But so technically speaking, 3 articulations, and here's a cross section. This is a sagittal cross section, and so you can see the posterior aspect of the patella has hyaline cartilage for that patellofemoral articulation, and then we can see we're adding actually a little bit of extra cartilage here. These are called menisci in between the femur and the tibia to kind of reduce stress. And so anyways, let's think about this little articulation site between the sesamoid bone and the patella, which is growing in the tendon and quadriceps and the femur. You can see a little bit of movement there, some tilting, rotation, up and down movement. But you know, like I was saying, you know, if the IT band is too tight, it can cause the patella to track laterally towards the lateral aspect of the lower limb, and then that can cause biomechanical problems. And you know, here's a nice X-ray, and you can see head of the fibula, and you can see the condyles, the femur, and intercondylar eminence. Okay. Just to remind you, before we get internally here, externally stabilizing the knee joint, in addition to muscles, we have the patellar ligament. Medially, we have that pes anzerinus, the goose's foot. 3 muscles from 3 different compartments, so sartorius, gracilis, semitendinosus, so pes anzerinus. And then laterally, we have IT band. Okay. Attached to Gertie's tubercle. Okay, so here's intercondylar eminence. These are medial and lateral condyle of the femur. You can see a ghosted patella here. Head of the fibula. Kind of, let's think a little bit too, like what some neurological structures are going to be doing here. So we're starting to think about the tibial nerve dividing in the popliteal fossa to, the sciatic nerve dividing in the popliteal fossa to a tibial nerve that's going to head south, and a common fibular nerve that's going to wrap around the neck of the fibula. So that's what we call a danger zone. It's really near the surface. And if you think about it, you're more likely to have some kind of traumatic force hitting the lateral aspect of your knee and the medial aspect of your knee, just randomly speaking. So think about like the game of football, more often you get hit here than here. So that head of the fibula and the common fibular nerve traveling near it, very exposed. This gets fractured a lot, that nerve can get damaged, and we'll think about that later in the course, what we would see. So anyways, just kind of thinking about some neurological structures in this vicinity. The knee joint is technically a hinge joint, so basically it's allowing mostly flexion and extension, but in flexion it can allow a teeny bit of medial and lateral rotation. So you might ask, what would be rotating it? Any of those muscles kind of crossing the knee joint from above. So hamstrings in particular, things like that. So you can see that here. It's not a lot of rotation, but a little. Okay? And if you want the details, you can get it in this chart. So if you look here, there's not much rotation. Okay? But a little. Just like that sartorius. Yeah, let's think about sartorius. ASIS. This is lateral. Head immediately past patella to pes anzerinus attachment site. So up here, it's going to flex at the hip joint. It's going to abduct at the hip joint, among other things. Down here, we're going to flex at the knee, but we can also medially rotate at the knee. All kinds of things, right? This can even generate lateral rotation up here at the hip joint. So at least 5 actions. Okay. So if you look at the osteology of the lower limb, we talked about this previously. The femur is not vertical; it is actually at an oblique angle relative to the vertical axis, and you can measure that difference there and assign a number to it, and that's called the Q angle. And that's to keep our center of gravity, our mass, in between our two limbs that we use for bipedal locomotion. So it's an evolutionary adaptation for bipedal locomotion, that bend. And it's greater in females than males, slightly greater. But there's always biological variation. So some people, regardless of sex, regardless of gender, have an even greater Q angle than the average situation. That would be a valgus situation. Some people have a slightly less Q angle, right? So I'll let your pathologist talk about the implications, but those can have biomechanical, can result in biomechanical issues if that angle is greater or less than normal. All right. But you can see how just the typical angle is going to put strain on the knee joint, okay? More than if you just had a femur and a tibial just vertically aligned. All right. Okay. So, like all synovial joints, this is a synovial hinge joint. There's a joint capsule. There's synovial fluid being produced. There's a synovial membrane. There's a lot of bursa here. Unfortunately, in cadavers, the bursa often are not that distinct after fixation. So sometimes people are excited to see bursa, and I always tell them there's a lot of bursa in the vicinity of the knee. And bursa are fluid-filled sacs designed to reduce friction related to moving parts. So all these tendons and things moving around. Here's that patellar ligament again, attaching to the tibial tuberosity. Here's our sesamoid patella. Here's IT band coming down here, attaching to Gertie's tubercle, and here's pes anzerinus. 3 muscles from 3 compartments. So we got 2 stabilizers, lateral and medial. And we got a stabilizer in the center, which is the patellar ligament. Okay. Now in the back, one of my favorite muscles, popliteus, you're only going to see if you remove gastroc and soleus, otherwise it's hidden. This is a really cool muscle that we say unlocks the knee. You know, if you want to start moving and standing and now you want to move, something like that, popliteus. And so the only way to see that is to remove gastroc and soleus. We have that in multiple cadavers. That's actually helping stabilize the knee joint in the back. Okay. Oh, I did have it in here. Okay, so we do this test, and the neurologist or the clinician is really interested in is the integrity of L2 to L4 spinal cord intact. If it is, then this reflex will be generated. But if I compare left and right reflex, and one reflex looks massively exaggerated, that might indicate an upper motor neuron problem. And if one side is drastically reduced, that might indicate a lower motor neuron problem, like you could see in polio or Guillain-Barré syndrome. So that's why they're doing that kind of reflex testing. But anyways, I put it in here just to kind of tie it into that patellar ligament. That's what they're tapping. Okay. Patellar ligament's also used for grafting. So some of you in here might have had this done, or you might know people who've had an ACL replacement, and sometimes they'll use a bit of patellar ligament to get material to function as an ACL tear replacement graft. Sometimes they'll get it from a cadaver, sometimes they'll get it from another part of the body, but you can get it from that patellar ligament. There's enough of it that you can take some of it. Oh, here's that cadaveric view of that cool popliteus muscle, and you can see posterior cruciate ligament. Actually, you can see posterior cruciate ligament from the back and the front, so we're going to look for it at the front and the back. Okay? But you can see how popliteus is actually helping provide a little stability to the knee joint too. And so this is a muscle that unlocks the knee, so internally rotates it. When we're standing, we say the knee goes into a locked configuration, and actually there's really little muscle movement going on in our lower limbs. It's like really energy efficient actually just to stand, almost using no muscles. Slight postural adjustments going on. But to transition from standing to walking, you have to unlock the knee, okay? Internally rotate. And so that's the popliteus job. A couple other things I want to talk about. So as you follow popliteus laterally, its tendon courses between the lateral meniscus, you see it right here, of the knee, and the lateral collateral ligament, which is the major knee stabilizer in the lateral aspect. And so, so it's separating lateral meniscus from lateral collateral ligament. Okay. In contrast, on the medial side of the knee, the medial meniscus, you can see it here, is actually attached to the medial collateral ligament. And because of that attachment, they're often in severe injuries, rotational injuries, they're often torn together, medial meniscus, medial collateral ligament. In contrast, lateral meniscus, lateral collateral ligament, they're not often torn together. They're not attached. What separates them? The tendon of popliteus. Okay. Oh, so here's a view of that lateral collateral ligament, and you can see how the tendon of popliteus, see it right here, is separating it from the lateral meniscus. Okay. Lateral collateral ligament, also called fibular collateral ligament. Question?
Did you say again which ones are tear together?
So, rotational, excessive rotational movements in particular often tear the cruciate ligaments. Sometimes You'll also tear a meniscus. Sometimes you'll also tear a collateral ligament. Sometimes you can tear all three. If that happens, it's typically the medial meniscus, medial collateral ligament, and ACL that are torn. And the reason the medial meniscus and medial collateral are often torn together is they're attached to each other. You can tear the lateral meniscus. You can tear the lateral collateral ligament, but they're not often torn together because they're not attached. What's separating them is the tendon of popliteus. Okay?
Thank you.
When you tear all three of those things, ACL, medial meniscus, and medial collateral ligament, that's called the terrible triad. Okay. Here's a cadaveric view, kind of cool. All right. So now we're going inside the knee and thinking about how do we stabilize this synovial hinge joint. And so we're going to use two cruciate ligaments, cross, so they cross each other. That's how they get their name. Two collateral ligaments, and we're going to see this like a lot of places in the body, both upper limb and lower limb, where there's hinge joints, even in the fingers and the toes. There's little collateral ligaments on the side of the hinge joint. Okay, so this is not the only place we have collateral ligaments, but these are the most well known. We worry more about tearing knee collateral ligaments than like the collateral ligaments of your fingers or toes, but there are other collateral ligaments anywhere you have hinge joints, flexion extension joints. You know what I mean? Okay. But these are the main ones. And so here's, you can see in this artistic rendition, the lateral meniscus is separated from the lateral collateral ligament. What's separating it? The tendon of popliteus. In contrast, the medial meniscus is attached to the medial collateral ligament. So they're often, therefore, torn together. If you look at this front view of the knee, okay, and we're going to see this in multiple cadavers. By the way, if you're presenting, if you want to have us see this, you got to actually flex the leg of the knee, reflect the patella, and then we're going to see this. Okay, you can't. If the leg is just extended, you can't see any of this. Okay, so you got to flex it to see that. So, but if you notice, and you're going to see this, we don't just see anterior cruciate ligament from this frontal view. We see a little bit of posterior cruciate right over here. All right. We don't just see anterior cruciate. We also see a teeny bit of posterior cruciate. And there's a little mnemonic that we teach. The mnemonic is apex and pain. So I'll walk you through it. So apex says that the anterior cruciate ligament goes from the front to the back, A to P, and it goes external. See that? It's heading laterally. This is the fibula, so this is lateral. Am I making sense? Okay. The pain mnemonic says the posterior cruciate ligament goes from the back to the front. And as it goes to the front, it goes internal. That's why you can see it here in the front on the internal side. Okay, see that? So they're called cruciate ligaments because they cross. And you can remember how they cross and what their trajectory is from apex and pain mnemonics. Does that help? Okay. So 6 primary cartilaginous structures really protecting the knee. 2 collateral ligaments, 2 menisci separating the femur and the tibia, and 2 cruciate ligaments. What the cruciate ligaments are doing is preventing excessive anterior posterior movement. What the collateral ligaments are doing is preventing too much sideways movement. And what the menisci are doing is, resisting compressive forces down onto the tibia from the femur side. Okay. So let's look at the medial collateral ligament. This is the guy that's attached to the medial meniscus. Okay. Here's its attachments. Really strong ligament, and it's attaching to the medial meniscus, like I was saying. Okay. Pes anterrinus runs above it. So, like if you see pes anterrinus in some bodies, you see that three-fingered tendon, the medial collateral ligament is going to be deep to it. Okay. All right. Both these collateral guys are taught in extension. So like you do this, they tighten up, you do this, they relax. Extend, they tighten up, you flex, they relax. Here's the lateral collateral ligament, and this guy's separated from the lateral meniscus. That's 80th time I'm saying that. By the tendon of popliteus. There's the tendon of popliteus going between lateral collateral ligament and lateral meniscus. All right. So, like I was saying, a lot of bursa. Look at this. Here's a suprapatellar underneath the tendon of quadriceps. We got some in the vicinity of the patella. We got infrapatellar bursa. I actually had a little syndrome involving this pes anterrinus bursa. I'm not sure really what triggered it. I was like in a train in China, and then long distance train, cheap economy class ticket, and then the next thing I know is like major pain right exactly where the pes anterrinus is attaching, and it lasted for like 2 to 3 weeks. I could barely walk, just major inflammation there. So I had bursitis of the pes anterrinus bursa, right? Weird. Anyways, you're not gonna really see these in the get out because after fixation, it's kind of unfortunately messed up. But you could imagine how they're nicely positioned to reduce friction. All these little moving parts of pes anterrinus tendons or patellar ligament, you get the idea. Okay. And any bursa can become inflamed, and then you end up with a situation called bursitis, which, like I just described in my case, quite painful, limited my ability to move, things like that. This is interesting. This is a potential so-called new knee ligament. If you look here, this is the major lateral collateral ligament. And what these folks are claiming is, whoa, look at this little guy here. There's a new ligament in the human body that we never knew about. We're going to call it the anterior lateral ligament. And I think that now people are saying it's just part of a lateral collateral ligament complex. Probably people in the past never thought of it as a separate ligament. So take it with a grain of salt. If you were dissecting for me, it's really cool to open up the knee joint. You'd flex the leg at the knee like I told you. You'd slice right through the patellar ligament, reflect the patella up, and when you did that, you'd look in and be really excited, I imagine, to see the ACL. Just in my experience, like, I don't know, I feel like people are really excited to see the heart, see the brain after you open up the cranium, and they often seem really excited to see the ACL for the first time. And they often think that's the ACL, right? And it's not. Sure looks like it would be an ACL, but it's not. It's not really running. It's not running externally, and it's actually just a little synovial fold, and there's some fat there, so that's like a little sucker's punch to the dissectors. You actually have to cut through that, and the ACL is. You can see it here. It's behind it. Okay? If you felt it on the cadaver, really different makeup. The cruciate ligaments are quite strong, quite tough. Okay. All right, this is very interesting. So the red lines are the synovial membrane. Remember, synovial joints have a joint capsule and a synovial membrane and secreted fluid to reduce friction. So this is where the membrane is. So the cruciate ligaments are actually outside the synovial membrane, okay? So they're not as lubricated as they might be because of that. And although they get some patient, but they're outside those membranes, okay? So they're in here. Look at the articular surface of tibia. Okay. Compare the shapes of the two menisci. So the lateral meniscus and medial meniscus, slightly different shape. This is a patella that's been reflected up, and this is a posterior view. In order to see this, you got to remove gastroc and soleus, and so you can see the beginning of posterior cruciate ligament, and you can see the end of anterior cruciate ligament. Just to remind you again, apex and pain. The anterior cruciate ligament starts in the front, goes to the back, A to P, and as it goes to the back, it goes external, it goes lateral. So here you can see it lateral. And the posterior cruciate ligament goes from the back to the front, P to A, and as it's doing that, it goes internal. So here we can see it beginning, and it's going to eventually head internally. Okay? And what they're doing, these crossing cruciate ligaments, is presenting excessive anterior posterior displacement of the tibia with respect to the femur, or femur with respect to the tibia, however you want to think about it. Okay? And you can test that laxity by, having the patient flex their leg at the knee, grabbing the calf, and then moving the tibia with respect to the femur. And you can examine the amount of laxity there. That would come with experience. The ability to sense whether there's more laxity than normal, or is it a typical situation. Both of these cruciate ligaments are subject to wear and tear, especially like excessive rotational movement, like in soccer, like in basketball, like in tennis, can cause these things to tear and to rupture. So not uncommon. And I'm not going to require you to give me these numbers. I'm sure any journal would give you slightly different numbers, but pretty common injury. Anyone here? Do you want to share? Anyone here torn a cruciate ligament? It's got to be someone in here. Usually I have at least one person. No one. Okay. ACL? Anything else?
A lot of medial meniscus.
And did they? It's okay. I'm just interested. Like, did they do a graft, or? So it's interesting. So in younger people, typically they'll do surgery and they'll graft the material, and oftentimes just complete recovery, and professional athletes get back to how you performed before. But like elderly people, oftentimes they won't do surgery. They'll just be like, no more, parkour for you, and climbing El Capitan, without ropes. But you can do height and walk. So it's sort of interesting that the treatment approach is different depending on age often. But anyways, really often rotational injuries is the key word you're looking for here. So this is one of many tests you can do. I'm not an expert on these. I'm not a PT clinician. I think the drawer tests actually aren't like the preferred choice anymore, but that's one way. Again, so you have the patient flex their leg at the knee, and you grab the calf, and you either move the tibia towards you or away from you. You're trying to sense, is there more laxity, more give and take than normal? If there's more give and take than normal, it suggests that the cruciate ligaments aren't performing their normal function, right? Which is resisting too much displacement there. Make sense? Okay. Same thing for posterior cruciate ligament. Okay. All right. So those are called the drawer tests. Drawer. Okay. Here's a view of the posterior cruciate ligament from the back view, but remember, it's not the only place you can see it. I know our intuition is, oh, the only way I'm gonna be able to see this is to like go in from the back, remove gastric. No, you can see it from the front too. You can see it from the front. There's a little guy kind of joining it called posterior meniscofemoral ligament. See it right here, coming in attached to it, just kind of aiding in its function. Okay, let's talk about the menisci, these little fibrocartilaginous pads that tend to wear out as we get older, which is a problem. They can also tear. And oftentimes people will tear a cruciate ligament and a meniscus. So, like I was saying, look at how they are slightly different in shape. So, here's lateral meniscus, and here's medial meniscus. Check out medial meniscus, more commonly injured. Why is it less mobile? It's attached to that medial collateral ligament. Here's a cadaveric view. So lateral, medial. Remember, frontal view. After we remove that synovial fat pad, we get this beautiful view of the anterior cruciate ligament. But we have a little peek of posterior cruciate ligament. See it? Okay. And remember, posterior cruciate ligament's going internal. There are these little extensions. I don't know. We could look. I don't know. I'm not sure we've ever dissected these out. These little coronary ligaments that run from the menisci down to the tibia, kind of help attach them. We could look for those coronary ligaments. Okay, so I don't want you to memorize any of this crap. Just know these are really common injuries. Okay, just put this in there because I thought it was interesting. This is just from one study. Okay, 10-year study looking at 6,000 plus patients. But anyways, oftentimes you can end up with this kind of injury where the ACL, medial meniscus, and medial collateral ligament are all torn. That's called the unhappy triad or terrible triad. And again, it's often a twisting, excessive rotation of movement kind of precipitating injury. The femoral artery, traveling down the femoral triangle, entering the adductor canal, ending up behind the knee. Okay. There's a problem. Inflection. You could cut off blood supply to the knee. That major artery is kind of getting compressed a bit. So what we do is this major arterial system that goes from the front to the back through the adductor canal, it sends little branches that wrap around the knee. If any of you are Catholic, you know that you get on your knees during the service. That's called genuflecting. Genu means knee from the Latin. You'll see that word a lot in anatomy. Anytime there's like a little bend, a little knee-like bend, genu appears. So these are guys that are going to the knee. So they're called genicular arteries, the arteries to the knee. There's some coming from above, wrapping around the knee, and there's some from below, wrapping around the knee. We're gonna look for the ones from below in the cadaver. To see them, you look for popliteal artery in the back, and just look for these little guys wrapping around the knee. Okay? So we'll look for inferior genicular artery. Right? Important knee circulation. Couple genicular arteries from the top, couple from the bottom, one in the middle, add it all up, and these branches of the popliteal artery to the knee, called genicular branches, they help maintain blood flow, they help maintain perfusion to the knee, even during flexion of the knee, where it might otherwise be cut off. Okay. Oh my God,
Ah, yes.
Thank you all. Yeah, 90 slides.